Okay, so welcome everybody to the second lecture of this week. We're nearing the end at week 11. So building on what we talked about yesterday when we were talking about issues around accessibility to different healthcare services, today we're really focusing on some of those issues around accessibility, but really focusing our conversations around issues in rural and remote communities, whereas yesterday we talked mostly about seniors and older aged individuals. So just a quick sort of recap from yesterday, because there have been updates in the past 24 hours since we were all together chatting in our lecture. So just to kind of refresh what we were talking about, we talked about health service accessibility really being marked or indicated by three main sort of indicators, we can call them. So we talked about the availability, the reliability, and the suitability of health services being really, really important in order to classify a health service being accessible for people. Now, we also talked about yesterday the kind of issue around vaccines, vaccine distribution for seniors in Ontario specifically. And we discussed some of those challenges that seniors do face, particularly in the sort of current setup of vaccine distribution, where a lot of seniors kind of have to make their own way to these vaccine clinics. Oftentimes they're maybe not in the most convenient of locations. And as we discussed yesterday, a lot of senior citizens do face issues around things like mobility issues, access to transport. So their access to those types of health services, such as vaccines, would be impacted. Well, in the few hours after we wrapped up that lecture, the Ontario government actually announced that they would be putting aside more money to make vaccines to seniors more accessible, because I think they realized that unfortunately the uptake, a lot of the vaccines were quite low in the population that's been sort of targeted for the time being. And so they've kind of mysteriously said that they're going to be planning a transportation program to help transport some of those seniors to those vaccine clinics a little bit more easily. So they haven't announced any specifics around this plan or this program, but hopefully some more details will come. But I just thought it was a very relevant sort of update to bring up, given what we talked about yesterday. Now, this brings us back to today's topic. And so today we're really focusing on issues of accessibility, but specifically around those rural and remote communities. So let's begin by just sort of thinking about what rural and remote are. Like, what do those even mean? What do you guys think of when you think of a place or a location that's rural or remote? And do these different concepts mean the same thing? Do they mean different things to you? What are your thoughts? So Zoe says less populated. Yeah. And if you have a perspective on one or the other, be sure to make sure that you say whether you're talking about rural or remote or both. So what else? What do you guys think of when you think of rural and remote settings? Anything else come to mind? Nicole says remote, not around anything. Okay. Grace says further away from resources. Sarah says, I would say that remote would be like a rural location that is further from other locations. Okay. So some of you are kind of making that distinction between rural and remote. Anyone else wanted to add anything? Do most of you agree that they are different? Do some of you think that they are the same or similar? If anyone wants to chime in. Reed says, I think they are different. Well, let's take a look. Let's see what those things mean. So usually when we talk about a rural setting, technically rural is kind of this socially constructed term. There's not really any clear or consistent definition. Different governments around the world, different countries around the world define it as a very different thing, depending on the context that you're in. And so there's not just one definition that's really available to describe a rural setting. That being said, some indicators that are used to classify whether or not a place is rural does include things like population size, population density, and in Canada, we often refer to anything rural as simply being outside of an urban population center. So these definitions can vary and they can be a little bit limited in terms of how to really define the scope of what it is that we would consider a rural setting, a rural community. On the other hand, remoteness is a little bit different actually. So remoteness is defined by the geographic isolation, and it often reflects very limited access to resources. So things like electricity, piped water, education, and even healthcare, which is particularly relevant to our discussions today. So although they are kind of similar concepts, certainly when we think about rural and remoteness, I'm sure many of us kind of envision a similar type of community, something very kind of rural, maybe quite idyllic, but they do mean subtly different things, rural and remote. So kind of keep that in mind as we go through today's lecture. Now, where do rural populations actually live in Canada? Again, this does vary quite substantially if you look across the different provinces. And so in Ontario, we're actually below the national average in terms of the proportion of Ontario's population living in rural areas. So we're below the approximately 20% average. On the other hand, in the more Atlantic kind of maritime provinces, they tend to be characterized as quite rural, as well as perhaps unsurprisingly, the territories are defined as quite rural. But again, this does vary quite a bit across the different provinces in Canada. Now let's talk about some of these challenges. Why are we even talking about rural and remote health for an entire lecture? What kind of issues might arise when we talk about accessibility to different health services? Well, the first challenge really is just about the population itself. And so the determinants of health and the population characteristics are pretty different when you compare rural areas compared to urban. So some of the things that may or may not impact the health status of rural residents could be something like incomes and educational attainment, because those do tend to be lower in rural communities compared to urban. There's also the issue of access to nutritious fresh food, which can be particularly challenging for remote communities that maybe don't have steady access or steady supply sources. Oftentimes it can be really expensive to transport things like perishable fresh fruits and vegetables. So just to kind of highlight that, this was a report done in British Columbia, and they were comparing the average price per month that a family of four would spend on groceries. And so they did find some pretty substantial differences depending on the region of British Columbia, with the north being the highest. So they pay the most in terms of their grocery bills for an average monthly bill. So this does kind of go to show just what kind of challenges we're talking about. And of course, there are issues of water quality. I think we did discuss quite a bit of those, particularly when we're talking about something like Indigenous access to things like water. Obviously, the reserves we have discussed throughout the course of this course that they do have some substantial challenges with accessing fresh drinking water, clean drinking water, and the limits that poses for those communities. Now, another challenge is, of course, geography. So this is probably a pretty obvious challenge, that the larger distances that you have in order to access something like medical expertise, clinics, services, the more chance you have that the particular health outcome will be impacted by this larger distance, this kind of inaccessibility to access those experts and those medical staff. This also does have an impact on ambulance response times. So the longer distance you have, of course, the longer it'll take for an ambulance, for example, to come to your community, to come service somebody who's in need, but also to transport a particularly sick patient who maybe needs that treatment elsewhere at another hospital that's located further away. So this particular study was actually looking at this response time And so they were comparing the survivorship of patients who had a longer response time before the ambulance would come to scene to treat them. And again, maybe this isn't a huge surprise that the longer that a patient had to wait, if they were experiencing cardiac arrest, the longer that they had to wait for that ambulance to come, the less likely that they were going to survive that particular incident. So, we cannot stress this enough that this is a really, really big issue in rural and remote areas that don't have this access to quick, timely care when they need it. Now, another really big challenge is the recruitment of medical workforce. And this is really difficult in many rural settings. And so many vacancies tend to go unfilled. What kind of impacts does this have on care? Well, of course, wait times go up if you have to wait longer in order to see a sort of limited number of doctors that are in that particular area. There also tends to be a lot of burnout among the staff that are employed there because their responsibilities are just so much bigger. They have to care for many types of patients. Some patients have particularly complicated histories that they have to kind of adequately care for. And as well, they are short-staffed, meaning that they kind of have to pick up the slack. If one particular staff member falls ill, then that just sort of adds that extra burden. Now, another reason that hiring staff is so difficult is that the community amenities in many of these rural communities is a little bit more limited. So the fact that a nurse might have to commute significant differences to perhaps work multiple jobs between different clinics can be a real deterrent for them to want to work in a community like that, where the distances and the commutes tend to be quite a bit longer. There's also a lack of transportation options. So of course, you do have to have something like a driver's license and have to feel very comfortable driving those long distances in order to work there. Another really tough thing is that, of course, medical staff do tend to work shifts. And so they really rely on the help often of their family members, their friends, in order to help them take care of things like family life, family duties, family chores. And so if you are trying to attract a workforce, maybe from the city into rural environments, you do kind of have to take that into account and offer things like childcare, give them options so that they feel comfortable being away from their families who are maybe located in other parts of that province or that country, whatever it is that we're talking about. So I do want to highlight this interesting figure. So this was a report that came out of British Columbia. And what it highlighted was that the number of productive hours, so these productive hours are just the hours that could have been filled had they had a staff member, but they were productive hours lost because there were issues of short staffing and there was no staff available to actually perform those set of hours. So that's what that means. And the report found that particularly among registered nurses who would have been working just sort of a general duty, as well as those who would have been working in operating rooms and emergency settings, those are the ones that really were needed. Those were the hours that went unfilled the most, particularly in those northern regions of British Columbia. And so, this does have impacts on what kind of care can be offered if staff members in these particular departments of a hospital, for example, are working with less staff. They're maybe choosing their sick days and their holidays carefully because they don't want to put too much burden on the other staff members that they're working with. So these are some of the decisions that have to be taken into account when we're talking about rural care and hiring staff. This brings us to this next issue related to staffing, and that's training. So another kind of issue that faces a lot of these rural and remote communities is the fact that the educational background of nurses and doctors does tend to be impacted. So on the one hand, because there's shortages, a lot of rural communities do have to hire staff members who maybe don't have the level of expertise that they ideally would have wanted, but they can't necessarily, choose staff members based on their wants and needs. They kind of have to accept a lot of the nurses or the doctors that are willing to come to their communities. So there's a difference there. Sometimes there's that mismatch rather. So rural registered nurses actually tend to have a consistently lower level of education. And this doesn't mean that they're, incompetent or not qualified by any means. It just means that maybe they haven't achieved something like a master's degree in nursing. Maybe they haven't done kind of further training or expertise in a particular type of nursing. They're probably more likely to be more sort of general nursing nurse practitioners who maybe haven't had that extra training. there's also disproportionately more international medical graduates who tend to provide care in many of these rural and remote areas. Again, this isn't because they are incompetent doctors by any means. It's just that we do have a harder time attracting Canadian trained doctors to these communities. So the doctors who may be trained in somewhere like the Caribbean or other parts of the world, those are the ones that do tend to accept those positions, those residencies in rural and remote areas in Canada. Now, this is part of the problem, mostly because medical trainees don't actually get much exposure to rural settings. And so many of them don't choose to do any clinical rotations in rural settings. Many medical graduates don't end up placing their rural kind of residencies high on their priority list because they haven't had the exposure. They don't really know what that's about. They're not really attracted to the idea of working in a rural or remote community. This hopefully will change as we start to implement some of those programs that I think we touched on in previous weeks when we talked about healthcare systems, because this really, really is a huge problem that results in a lot of short staffing and a lot of shortages of really critical medical staff in rural and remote communities. So just to kind of compare here, over 80%, closer to 90% of urban nurses are regulated registered nurses. Compared to rural and remote, that percentage falls below 20%. So the registered nurses are just those nurses that actually have a university bachelor's degree in nursing, for anyone that doesn't know the differences here, whereas rural and remote communities do tend to employ more nurses who maybe are nurse practitioners. Maybe they haven't had that sort of extra training, that university or master's degree in nursing. So there are differences in their qualifications. Yeah, question. Oh, thanks, Regina. Have a good day.
Yeah, you too. Bye, everyone.
Okay, so this brings us to another issue around rural and remote healthcare, and this is the issue around limited care capacity. So we've talked about this before in kind of how the health system is set up in Canada and what the challenges are of setting up things like hospitals and ensuring enough beds are available across such a vast geographic place like Canada. But this is particularly challenging when some kind of emergency, such as an infectious disease outbreak, happens. This is because these outbreaks do require a lot more medical infrastructure. They require resources. So something like a staff or a medical expert might need to be brought into a rural or remote community if they are facing the potential for a big outbreak of some sort. It also requires specialized equipment, medicines, and these really need to be coordinated at a level that a community that just doesn't have that expertise might not be used to. So when this does happen, hospitals can very easily get overwhelmed because they do have a limited capacity for the number of beds available. For example, many of them only have 1 or 2 operating rooms, and so they have to be really careful to make sure that they don't overwhelm their systems. Now, if this sounds like it could never happen, well, it did happen. And this is why many medical experts were so concerned at the beginning of this particular pandemic and how we would potentially plan for outbreaks that would happen on First Nations or Indigenous territories. So back in 2009, when we had the H1N1 swine flu, I'm not sure if anyone here would have remembered that. It was quite some time ago. But what ended up happening was that even though as a whole across Canada, the swine flu pandemic at that time never really took off to the level that certainly COVID did, but also to the level that health experts thought it could. So luckily it was kept fairly well contained within the general population of Canadians. However, for reasons that are still a little bit mysterious, the swine flu did really take off in some Indigenous communities, particularly on some of the remote reserves in Manitoba as well as Northern Ontario. They did have some pretty full-blown crises related to the H1N1 outbreak. So at one point, actually, the Indigenous people in Manitoba comprised more than 2/3, so more than 66% of all flu patients on respirators at the kind of height of that outbreak. So a pretty significant portion of the population was Indigenous that suffered the consequences of this. Now, what the controversy around all of this was that kind of at the height of this outbreak, Health Canada, because as we know, federal jurisdiction is responsible for Indigenous health affairs, So Health Canada came under fire because many of these Indigenous communities were asking for more help. They were asking for things like, hand sanitizer and things like that, more masks and more PPE, things like that. And Health Canada actually hesitated from sending things like hand sanitizer because they were concerned that people on reserves would ingest the alcohol-based gel. So some just very negative kind of racist perspectives that emerged out of what Health Canada was kind of thinking about. In addition to this, and this was something that really made news at the time, instead of sending things like more staff, which the communities were asking for, Health Canada sent eventually things like masks and gloves, but also body bags, because, for whatever reason, they thought that those would meet the needs more of the communities than perhaps sending more staff or more money to hire and recruit more staff in those communities. So this was a very, very contentious issue at the time. And I think many communities are still very distrustful of the government and how the government responded back then to that outbreak. And certainly these types of fears and concerns would have played out now during this COVID pandemic, because a lot of those wounds never really healed between those communities and the federal government, and what was seen as a real kind of slap in the face at the time for how to respond to a real public health emergency. So hopefully, we've moved on from a scenario like that, and we will hopefully deliver more compassionate care going forward. So what is the state of rural and remote healthcare in Canada now that we've identified some of those main challenges and main issues around the delivery of care? Well, perhaps unsurprisingly, less likely to receive medical care by specialists if you're living in a rural or remote community in Canada. And again, this comes into a lot of those issues, right, where we talked about how to recruit staff, the problems with really having a specialized or highly trained workforce. In many cases, it also just isn't economically viable to hire one specialist in a remote community that maybe doesn't have the population or the number of sick residents that would really require the care of that specialist. So what ends up happening is that many members of those communities, particularly in the north, do have to get flown to southern Canadian cities in order to receive care from specialists. Now, another sort of consequence of this is that if you have less hospital access, because there do tend to be fewer of these hospitals, this means that treatment does often get sort of sidelined to other types of settings. So particularly in many rural areas of Canada, instead of treating people at hospitals, they might just treat people at a local community health center, which is adequate for certainly some types of treatments that might be required. But they might also send people to nursing homes or long-term care homes that maybe would have benefited from some sort of extra intervention, medical intervention from a more specialized clinic. So this does impact the type of care that you might receive in a rural setting. You might not be sent to a hospital right away, certainly not unless it's really deemed an urgent or emergency kind of health issue. So again, this does match up with what we see in terms of where nurses tend to work. So in all of Canada, the vast majority of nurses do work in hospital settings. But when you look specifically at rural nurses in Canada, many of them do instead work in those community health clinics as well as nursing homes. So there is a difference in terms of what type of job and what type of work a nurse will end up doing if they choose to go to a rural community. So how do these different challenges that we've discussed actually impact health outcomes? Well, the more remote that you are, the more remote of an area that you live in, the more likely you are to actually die of a treatable disease. So why does this happen? Well, again, many of these issues that we've been talking about over the course of today. So the longer that you have to wait in order to access, for example, an ambulance service to take you to a hospital, the further you are from that hospital, the more likely you might die in the meantime from that condition that would have been otherwise quite treatable, quite preventable. So this is why you can also think of this as sort of unnecessary deaths that tend to happen more frequently in rural and remote areas. This is particularly true of men. as we know, for many reasons, men do tend to have higher mortality than females, certainly earlier mortality. And so this does play into that and the types of urgent care that would be needed or that would have benefited those populations had they maybe received that intervention earlier. For anyone wondering, what is a treatable mortality? What is a treatable or unnecessary death? Well, it includes things like infections or things like respiratory and GI diseases, so gastrointestinal, even maternal or infant kind of infections that happen post-labor or during delivery, things that would normally be treatable had you had sort of a more sophisticated health service in place or available at the time. Now, how does this impact emergency care and emergency departments in rural and remote settings? Well, again, they do have usually more limited access to some of those things like advanced imaging, advanced medical equipment, things like MRIs, and of course, less likely to be treated as by a specialist, as we mentioned. There's also something worth pointing out that in Canada, the vast majority of emergency departments in those rural settings are really operating as these sort of quick, acute, urgent care clinics. So they're not really able to treat patients with more sophisticated level of emergency health issues. And usually those patients then have to get shipped to a further away hospital, one that has a trauma center. And so something like 50% of these emergency departments in rural settings don't actually have that quick access to a trauma center. Most of them are a significant distance away from them. We're talking more than 300 kilometers or so. And so again, this does impact the timing and the access to quick care that people in these communities are able to get. Now, I do want to mention as well birth outcomes in rural and remote settings. On the one hand, babies born in rural and remote settings can be healthier in some aspects. They tend to be exposed to fewer kind of harmful aspects of pollution, certainly. And we talked about in earlier lectures how babies born in rural areas can actually have some immune system benefits. They might be less likely to develop things like allergies or asthmas. However, in the context of healthcare accessibility and what kind of accessibility issues that mothers might face in these rural and remote communities, these might actually more so tend to lead to adverse birth outcomes in rural and remote settings compared to urban counterparts. And this is said to be mostly tied to health inequalities. So what do you guys think? What kind of health inequalities might be present in a rural setting that might impact the birth outcome of a baby born in a rural or remote community? Can you guys think of any? Any sort of socioeconomic determinants of health, anything like that? Sarah says lack of access to nutritious food. Yeah. Any others? Maybe no or little access to a midwife. Yeah. Any others? What about something like income? How might income inequalities maybe exacerbate certain adverse birth outcomes? Prices of baby formula in remote places are really high. Yeah, absolutely. Reed says little prenatal care. Yeah, so you guys got some good ideas there. Yeah, so again, something like access to prenatal care, which Reed just mentioned, access to supplements, also the distance to the obstetrician or gynecologist that you're being treated by, certainly if you need a C-section or an emergency kind of procedure during labor, then that could be a particularly, sticky situation that a mother might get herself in if she's living in a rural and remote community and then might need to get flown to another city in order to actually deliver her baby. There's also the fact that rates of smoking and poverty do tend to be higher in rural and remote communities in Canada specifically, but also in other contexts. Being overweight is also a little bit more common in rural settings. And so this does have impact on the health of the mother who is delivering the baby, right? She kind of is already at this disadvantage in many ways because the mother might have a different health status compared to, let's say, an urban mother who has a very different kind of life style or life setting around the time before she became pregnant. There's also worth mentioning the difference between First Nations and non-First Nations. But first, I'll just highlight these differences in weight and smoking rates. So as we see, as you go into the higher income quintiles, you do tend to see a drop off of these smoking rates as well as rates of being overweight. But that drop off is less so in rural contexts. So among rural mothers, they do still tend to be more overweight and they do still tend to be more likely to be smoking during the time of their pregnancy compared to their urban counterparts. And just to highlight this difference here between First Nations and non-First Nations, in both contexts, the rate of infant mortality here is lower in urban compared to more rural environments. So that's consistent across both First Nations and non-First Nations mothers giving birth. However, the numbers are quite different. So the rate of infant mortality for any level of rurality or urban setting is lower among non-First Nations mothers compared to First Nations mothers. And particularly among the rural First Nations mothers, that rate of infant mortality is quite a bit higher compared to some of these other settings in more urban and non-First Nations mothers. So this does result in some actual kind of tangible negative health outcomes that have been measured and have been consistently kind of looked at. And this study was actually done in Manitoba, for anybody wondering. So what are the ongoing challenges now that we've kind of talked about all these? Well, there is still this issue of the closure of many rural hospitals and clinics due to staffing shortages or people retiring and not being able to recruit new staff. And this is particularly troubling in places like the North. So just this past summer, actually, this was in the news. There was a birthing center that was in a pretty remote and isolated community in northern Nunavut called Rankin Inlet. And when the only two midwives that were working there, living in the community, who were of Inuit descent. So when they retired, or they didn't retire, when they left, they voluntarily chose to leave the clinic because of the issues that they were dealing with at this clinic, such as short staffing and just feeling a lot of stress and burnout from being the only two staff members there. So when they left, the government actually had to shut down this birthing center. And from here on out, until they're able to find a solution to this, the mothers in that community are going to have to be flown to other settings in order to give birth, in order to access some prenatal or postnatal care. So this does have real life consequences on many kind of health outcomes in these rural and remote settings. There's also the issue of centralization of services, particularly as governments try to look for efficiencies in the healthcare system. There is a tendency to want to centralize things. Why build a remote clinic there when you can maybe build one that services more communities, but they might have to travel a little bit to get there. So for many reasons, we are always looking for ways to kind of keep costs low, and that does tend to have an impact on those rural communities. There's also the fact that in rural settings of Canada, most of the healthy young populations tend to leave. Many of them try to go to university or go to college in other cities, and many of them leave behind this kind of older and sicker population of residents. Now, coincidentally, during COVID, we're actually seeing a little bit of a reversal of that. So many younger people are leaving the cities and going back to some of those rural communities. But it remains to be seen how long that will last, or whether this kind of phenomenon will actually last post kind of COVID time. So we'll see. Now, this brings us to some case studies that I wanted to discuss for today. So hopefully we still have enough time to get through this. But I know that we've spent a lot of time today, as well as yesterday, talking about the context in Canada. And certainly there are tons of issues around rural and remote care in Canada that we could talk about. But I did want to highlight some of them that do take place in other nations, particularly lower income nations, because I think it is an interesting kind of example to contrast. Even though issues are bad here and could be improved here, they are also bad in other places of the world. So let's take a look at some of these. So starting off with discussing impacts of infrastructure that's lacking in many rural settings of kind of lower income developing nations. The fact that we're talking about access to hospitals, certainly that is an issue here in Canada, but in many places of the world, we're talking about just basic access to even a single, doctor or a single clinic in many communities. So what ends up happening is that hospitals and clinics try to offer just a whole range of services. Many of them serve as sort of preventative as well as diagnostic, as well as emergency treatment centers in these rural communities, because they really have to be equipped to kind of handle a multitude of potential issues that come their way. So I do want to highlight one little study that was done in a very rural community in Uganda, which is a country located in sort of central sub-Saharan Africa. And so what the study was looking at there was that they set up a clinic in a rural part of Uganda. And let me bring this up here. So this clinic was located in a community called Ruhoko. Hope I'm pronouncing it correctly. And what this community looks like is that it has no roads. It has very little formal infrastructure as we know it. And the study authors were interested in seeing how these issues around accessibility, given the very remote and sort of isolated setting, how that might impact the uptake of something like HIV antiviral preventative medication. So what the study looked at was what different features, something like distance, for example, how that would impact the likelihood of people who would sign up to go to the clinic and go access these anti-HIV medications. So what did they find? Well, given the fact that many of them had to travel upwards of 10 kilometers just to access the health clinic in question, it wasn't surprising for them to find that even those who were walking just over 2 kilometers were less likely to access that preventative HIV treatment. Another kind of feature that they found was that even the walking time was had an impact on whether or not patients in that area would access that anti-HIV medication. So for the most part, they found that anyone who had to walk more than 30 minutes was not going to be likely to go access that medication. And they also did look at other features such as road difficulty. So if the road was particularly, or I should say maybe trail was particularly difficult for them to access, how that would also impact the willingness of people to go and seek that type of care. So this just goes to highlight, I think, that some of these issues that we're talking about in terms of rural and remote care, it's a whole other type of issue in many other parts of the world where something like road quality is a significant issue. Something like walking time to your nearest clinic, that might take several days or several hours for many people who need to access care that they need. So it's good to sort of take that perspective and keep these things in mind. Now, another sort of interesting issue that I wanted to raise was the impact of conflict on rural healthcare access in many parts of the world. Of course, there is the aspect of war, and certainly injuries from any conflicts, any wars do require very specialized kind of different care than if you're talking about chronic disease prevention in a place like Canada. And so this does impact what kind of care people can get, specifically if they're fleeing violence, if they're living in a place like a refugee camp where most of their care is coordinated by international agencies, people like Doctors Without Borders, and occasionally they do get access to the local healthcare system of wherever the, the refugee camp is located. But this does have an impact on what kind of care that they are able to seek in that particular setting. Now, corruption is also a really important kind of phenomenon to keep in mind in these type of settings. And in fact, recently in Afghanistan, 74 government officials were charged with embezzling coronavirus response funds. And the locals were actually not surprised by this finding. There's very little trust in their government officials there because of the history of kind of war and violence in recent years. And the locals there are quite concerned that the supply of vaccines that eventually make their way there will never end up making it to the people that would most benefit from it, certainly sicker, more rural populations. In fact, it's kind of anticipated at this point among the locals there that politicians will tend to hoard the vaccines and really just distribute it to their friends and family. So an unfortunate scenario in many of these kind of countries that have been impacted by conflict. Now, another issue I wanted to raise was the impacts of the status of women on rural healthcare access. So women's healthcare is in many places of the world kind of reliant on their husband's approval or their husband's willingness to help them seek care or seek treatment for a particular issue. Oftentimes, a husband or a male relative is kind of in charge of that decision-making and the permissions around whether or not you can access healthcare. So this was a study done out of Bangladesh, and what they found was that in rural settings, usually it was the husband alone who would be making the decisions around the female partner's healthcare, as well as the child's healthcare if they had children in their family. Another thing they found was that particularly around antenatal care, how this had impacts. So if it was a husband alone who was making the decisions about healthcare, health services, access to these types of things in the family, the mother as a whole was less likely to get that antenatal care, less likely to go get it. This was also true if they jointly came to make this decision, although I guess you could raise the question of how jointly it would have been made, compared to, let's say, urban environments, and compared to, let's say, if it was just a mother alone who was in charge of the decision-making around antenatal care. So maybe this is a source of caution. We shouldn't put husbands or other male relatives, other men in charge of female reproductive health all the time. Certainly, many women in many places of the world would benefit from more independent, more kind of agency around making their own sort of healthcare decisions. So this does have actual impact on whether or not a female or a mother will receive care for something like, complications that might arise during labor or delivery. So important to keep in mind. Now, there's also some unique impacts of the community dynamics on rural healthcare. So in many small, rural, isolated communities where most neighbors know each other, there's really kind of a lack of privacy anytime you're talking about health issues. It can be particularly difficult to try to convince people in the local community to go seek care because there might be a lot of stigma associated with going to a clinic if you know that everyone on your block is going to know that you went to that clinic. So this is a particularly kind of unfortunate issue that does come up in some rural parts of Africa that are dealing with kind of epidemics of HIV. And so what ends up happening is that testing rates for HIV do tend to be pretty low in a lot of rural environments, not only because of the lack of access to testing treatments and care, but also just due to the fear of stigma. They really don't even trust that the local nurse who's administering the test wouldn't go and tell everybody in the community because that nurse is from that community and everybody kind of knows each other. So this is seen as a very, very significant barrier to actually going out, receiving tests, receiving care for many health issues that do carry a lot of stigma, particularly those related around HIV. So what this particular study found, and this was a study done in South Africa, was that when they introduced something like a mobile van where someone could kind of make an appointment, it was offered as a little bit more of a private setting. The mobile van would be a little bit more discreet. You could kind of tell the nurse there exactly when you wanted to go access that particular test. As well as home-based testing, they found that the home-based testing was the most effective way to actually increase the uptake of testing related to HIV. So it does go to show, I think, just how important the issue of patient privacy and really making sure that you are taking into consideration some of these other factors when you're talking about accessibility to healthcare, because of course, even if you offer services, you have to make sure that people are willing, they feel comfortable, and they feel secure enough to go access them themselves. Now, there's also a significant impact just by the reason of the lack of population data in many rural parts of the world and how this might impact healthcare delivery. So the delivery of healthcare is particularly difficult in areas that don't actually have something like a reliable set of census data, because how on earth do you know where you should send doctors or where you should send particular medications, how much of those medications you should send out to places if you don't have a firm number or a firm idea of the number of people in a particular geographic location? So this is a particularly big issue in many parts of the world. So what do you guys think? How can we perhaps map the unmapped? How can we go about finding out how many sick people a doctor might need to treat in a particular remote location that doesn't have any reliable population data? Do you guys have any ideas? Nicole says surveys. Yeah, so you could take a survey of, maybe part of the community and just sort of extrapolate perhaps the population from that. Any other ideas? So Sarah says visiting the villages. Let's say you're talking about a disaster zone where, a tsunami has just swept through the area or something like that. How would we maybe quantify populations in places that are not safe enough to actually send out staff or anything like that? Do you guys have any ideas? Sunima says send more doctors than you think are needed. Yeah, might be a little inefficient, but I suppose you could do that as well. You could assume that the whole population needs care, maybe consider the sick people and populations in other similar locations. Yeah. Let's take a look at some of the options. So increasingly, geospatial methods are used for counting people in remote areas. And so I think someone at the very beginning of the term was asking me, how relevant something like GIS training is for something like health and geography. And this just goes to show you that sometimes it's extremely relevant and extremely important. So particularly for a lot of organizations, Doctors Without Borders, health organizations like that, they do require a lot of expertise around things like GIS and working with remote or high resolution satellite imagery in order to study changes in land use. Because if you can study the changes in land use, let's say how a particular landscape looked a month ago versus now, then you can see subtle differences that are likely to represent areas of human settlement. Right? So if you know that a human has left some sort of kind of footprint on the planet, then you're able to sort of quantify roughly just the number of people that might be living in a particular area by looking at that satellite imagery. So this is actually commonly done in many kind of disaster scenarios when you just need a very quick kind of crude calculation, or even just to know where it is exactly that you should send aid, because maybe there's really no reliable way of even knowing the general sort of coordinates in order to find out. So this is done. Sometimes you can count the number of things like tents. You can count any sort of changes to water that might be there, maybe pooled water you might notice forming because someone has established some sort of drinking water well or some sort of pool to wash clothing, things like that. And so these are the types of changes to land use that are often looked for if you are mapping these things. Now, another interesting kind of technology I wanted to highlight is there's this, I think it's an app, I guess it's also a website called 3 Words. And so every what 3 words. And so every 3 meter square of the world, this app has given a unique combination of 3 words. And so this is really useful for places in rural or remote communities where there's no road. You can't really send something like an ambulance. You can't really send something like a doctor an address to go treat people because there's no real way of directing that aid that you need in that specific location. So this is actually used in some parts of the world just to be able to say, okay, this is where we are. If we're talking about something like BSB, you could say you are located at Foods Tripled Warping, and that is where you should go send aid. So it is sort of a useful way to get around some of these challenges around places that really are not on the map. And yeah, feel free to go find this if you think it's kind of cool. I spent a whole evening looking at various 3 words that represented different places that I was familiar with. And so I thought it was kind of interesting. So that brings us to the end of today, and we are right on time. Good. So as usual, let me know if you have any questions. And hopefully you guys have a good rest of your day.